Can you see the entire board? Okay, fine. So Gene and I are socially distanced. We have masks off now because I don't like wearing a mask when I'm just by myself. We're going to talk about HIV today. We're just going to do a shop talk because Gene told me that's what we were doing, and I didn't prepare a PowerPoint, so now I look like a slacker. But the things that nobody understands are meds and what's what, and how to deal with them when you get inpatient and drug-drug interactions. So we're going to start with that, and then we'll go from there. I can't really read the comments, so if there's anything important, sorry, we'll come to it at the end. If there's absolutely something that you need to know, just unmute yourself and yell through his phone at me. All right, so 5 classes of HIV medications, 4 classes that are important, and I think overall we're probably going to talk about maybe 12 to 15 drugs. So the first class, the unimportant class of HIV meds, the entry inhibitors, there are 2 agents. Got Maraviroc and enfuviratide. So enfuviratide is an old drug named T20. It's a sub-Q injection. It makes everybody feel like they have the flu, and no one uses it anymore. So it actually attaches to CD4 right here and blocks the conformational change that lets you get into the cell. So this one binds CD4. But not really important. You'll never see anybody. I don't have anybody on it. The other one is Maraviroc. So remember that to get into the cell, you need to bind to both CD4 and the co-receptor. The co-receptors are CXCR4 or CCR5. You can pick either one. The HIV has what it likes to use. Doesn't matter to the cell. So Maraviroc is a CCR5 antagonist. So it will selectively bind the CCR5 on the surface of your CD4 cells and will inhibit HIV from binding to the cells. So if your HIV virus, we classify them as R5, X4, or dual mixed. R5 means that your HIV only uses the CCR5 receptor. X4 means it only uses CXCR4. Dual mixed means that you can use either. So when you get a profile at the beginning of your treatment, if you're going to use this drug and it is X4 or dual mixed, this drug is completely worthless because the HIV will just move along from the CCR5 that it is blocked and find something else to use. So you can only use Maraviroc if you have screened your patients and their HIV is R5 tropic only. R5 only from Maraviroc. It's a twice-a-day medicine, so that kind of sucks. And it's actually inferior as initial therapy. So we never use it initially. Sometimes we use it as salvage. So this class of drugs is pretty worthless. You rarely will see folks on it. You might see someone on Maraviroc if they're on a salvage regimen. All right, so you missed this opportunity. HIV binds here. It shoots all of its products into the cytoplasm. So you've got viral RNA, and it brings with it all of its delightful little enzymes that it needs. So the first thing that happens is that its viral RNA finds its reverse transcriptase and changes itself from RNA into DNA. So there are 2 classes of drugs that hit the reverse transcriptase, the non-nucleoside reverse transcriptase inhibitors and the nucleoside reverse transcriptase inhibitors. The Nrtis are direct agonists. Direct agonist. It sits right here in the binding group and prevents the HIV RNA from binding to reverse transcriptase. Therefore, you can't do anything. So a direct antagonist. The Nrtis are slightly different. So they're nucleoside analogs. So you're going along, you've got the RNA in the binding groove, it's making the complementary DNA strand, it's putting in, and then it hits one of the Nrtis, and then the reverse transcriptase says, what in the hell is going on? There is no 3' hydroxyl group on this particular molecule. How the hell am I going to add something else? It gets frustrated, it shakes, and it falls off, and the DNA strand degrades. So these are chain terminators. So it starts, they allow reverse transcriptase to start making the complementary DNA strand, but it doesn't come to completion. This stops them. So there are 3 important Nrtis. You guys know all of these: efavirenz, rilpivirine, and etravirine. I'm going to hit the high points only. Efavirenz, nobody uses anymore because it has lots and lots of CNS side effects. So somewhere between 10 and 20% of people will have vivid dreams, is the one that you hear on the boards, but it can cause anything brain related. So anxiety, depression, insomnia, hypersomnia, fatigue, headaches, anything CNS related, efavirenz can cause. Efavirenz used to be pregnancy category X because there were question mark neural tube defects. But because efavirenz was the NNRTI in the first 1-pill combo, it was used in sub-Saharan Africa, and that data hasn't really borne out. So now it has no pregnancy category, and the recommendation is don't start women of childbearing age on this, but if they're on it and they get pregnant, ride it out. That's it on efavirenz. CNS problems and question mark pregnancy, and nobody uses it anymore because of all the CNS stuff. Rilpivirine is the 2nd generation NNRTI. Rilpivirine needs acid to be absorbed. So you cannot have patients on PPIs and H2 blockers with rilpivirine, else you won't get effective absorption in the gut, and you won't have effective levels, and they'll fail the therapy. So rilpivirine, remember, needs acid, so no acid blockers. It's inferior.
Like Tums, like if they're taking tons of Tums.
So Gene asked about Tums. So if you're taking Tums or potentially H2 blockers, you have to take this at least 2 hours before or after the medication for it to be effective. This is really important if you're starting someone on this as a new medicine when their viral load is high. It probably matters less when you've got them undetectable because you don't need as high of a level to keep someone undetectable. It's also an inferior therapy if their initial viral load is greater than 100,000. So if they're really sick, it's not the best drug to start them on because it has a low threshold to resistance. Etravirine is the 3rd NNRTI. It's the salvage NNRTI. When it's resistant to both of these, etravirine's usually good against it. The problem with etravirine is that it has lots of drug-drug interactions. So it is both a CYP450 inducer and inhibitor. Every time I put someone on this drug, you have to run a full medication reconciliation because it inhibits some stuff, it induces other things, and you have to know what's what. I don't remember all of them. I just put them in Epic, and it tells me what it does to what. But anytime you see someone on etravirine, remember, think, oh my God, are they on anything important that I need to worry about, like Coumadin or Synthroid or yada yada. Boom. So isn't that easy? So we have now gotten through 2 of the 5 classes of HIV medicines, and there are really only 2 drugs that you're going to see so far. All right. The NRTIs are the workhorse of HIV treatment. There are 5 important ones. One of them, AZT, is only important sort of historically. It was the first NRTI created, the first drug we used to treat HIV. The only time we use it anymore is for pregnant women who are giving birth and the babies born to pregnant women. It reliably causes increased MCV. So if someone is on this for treatment and their MCV isn't 110, they're lying to you and they're not taking it. So it always causes macrocytosis. It doesn't always cause anemia, but it can cause anemia. So always macrocytosis, a lot of times anemia with AZT. You only think about it for babies born to pregnant moms with HIV. The guidelines here, we give it to everybody. Probably undetectable moms don't need it, but no one will ever do that study because it's unethical. All right. And then we've got 4 other ones. There are really only 3 other ones, but they have 4 different names. So we've got lamivudine, and abacavir. And we've got emtricitabine, and tenofovir. These 2 drugs are the exact same drug. You can't use them together. They're the same drug. 2 different companies own the rights to them, and they have like one little side chain difference, but you can't use them together. Lamivudine and emtricitabine are also both Hep B active, so you can use them for treatment of hepatitis B if they're co-infected. And I have never stopped either of these medicines for side effects. The class-wide side effect of the Nrtis is lactic acidosis, hepatic steatosis. That happened with the older agents that we're not even talking about, like stabutine and didanosine. Not so much with the newer agents. But literally the only thing you have to know about these 2 drugs is not to use them together, and they're effective against Hep B. Abacavir is the only important NRTI that is not effective against Hep B. And abacavir is the weird one where you have to test people for genetic mutations before you start them on it. So you have to get an HLA B5701. If it is positive, you put anaphylaxis as their allergy to abacavir in the chart. If you give them abacavir and they develop a hypersensitivity reaction, the first time they get transaminitis, they get rash, they get serositis, you stop it, they get better, you re-challenge them with it, and they die. So don't give those people abacavir. So the negative predictive value of a negative HLA B5701 is about 99.9%. So if they don't have this gene mutation, it is very, 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 very unlikely they will have the abacavir hypersensitivity reaction. The positive predictive value of the HLA test is only about 30%. But if your reaction 30% of the time is death, that's enough to make me never use it. So even though the positive predictive value is low, we have other options that we can do, so we don't use abacavir for those folks. Tenofovir is the one that gets all the bad press. You guys see pretty much everybody is on these 2 drugs. Tenofovir has 2 forms, TDF and TAF. TDF, it's a D because it causes all the problems. Kidney dysfunction, and decreased bone mineral density. So, when you see somebody on old tenofovir dishydroxyl fumarate, TDF, think about renal dysfunction, bone mineral density loss, and Fanconi syndrome. So you're looking for glycosuria and proteinuria. Folks who are on tenofovir alafenamide, TAF, less likely to have kidney and bone side effects, but still be on the lookout for them. Treats hepatitis B as well. All right, I broke these up into these categories because these are single dose combos as well. So emtricitabine and tenofovir is Truvada if you have the TDF, and it's Descovy if you have TAF. Lamivudine and abacavir is Epsicom. So those are the two NRTI pills that you might see more frequently. Literally, that's all you need to know about that. Look at that. We've gotten through 3. We've gotten through 60% of the classes. And you need to know 6 drugs so far, and you're a master of HIV. It would have been nice when they were first naming drugs if they had made everything end in the same letters, depending on what class they were in, but they didn't. So we think of the VIRs as being protease inhibitors, but they totally screwed us with the back of it. So I'm sorry you have to memorize that. I'm sorry. Memorize it. Okay, the integrase inhibitors. Integrase inhibitors. So now you've missed your opportunity. HIV has made its double-stranded DNA. It's jumping in here into the nucleus. It's got integrase right here. It's already gotten into the nucleus before it. It's going to tear open our own DNA and insert the HIV genome. Integrase is going to block that. It just is a direct inhibitor of the integrase enzyme. There are four integrase inhibitors, and they all end in tegravir. So they got their shit together when they got to the integrase inhibitors, which are the newest class of medicines. So raltegravir, elvitegravir, dolutegravir, and bictegravir. So this class is easy. The best part about the integrase inhibitors is that there are essentially no drug-drug interactions except for one important one that we're going to talk about. They also have very, very few side effects. There are cases of increased CK and rhabdomyolysis with the integrase inhibitors, and early cases of SJS with raltegravir. So watching for rash, watching for myopathies is important, but otherwise these are pretty well tolerated. Dolutegravir is probably the most commonly used one currently. Dolutegravir has two idiosyncrasies that you should know about. So number one, there's this question mark neural tube defect. So this came out about 2 years ago. We don't use dolutegravir in pregnant women anymore. It's another one where it's, I don't know if this is real or not, but we're not going to take chances with it. So we lost dolutegravir for pregnant women. And dolutegravir has one super important drug-drug interaction because it's with a very common medication. And who's going to type in the medication that it interacts with? Dun, dun, dun. Important, common, general medicine medication that it interacts with that treats type 2. Whoa! Christina for the win. Awesome. Metformin. So it decreases the concentration area under the curve of metformin. I'm sorry, it increases the area under the curve of metformin by 50%. So if you put someone on dolutegravir, you have to do a 50% dose reduction in their metformin with a max dose of 1 gram a day. It also interacts with carbamazepine, which is less important for us. I've never prescribed that, but dimazepines, it interacts with those two. All right, so we have now made it through 4 classes, and we need to know 1, 2, 3, 4, 5, 6, 7, 8 kind of weird things about meds. We're at the protease inhibitors. So we screwed up. We missed our chance here. HIV got integrated into the DNA, and then it started to shoot out its protein products. Thankfully, it's stupid, and it makes them all combined on a chain, and they're of no use unless protease is hanging around to chop the chain up and to help it package its virion so that it can get out of here. So there are about 100 protease inhibitors. There aren't that many, but whatever. There literally are 2 important ones. Historically, ritonavir is important because it was the first protease inhibitor. If you give it at HIV treatment doses, they will get projectile vomiting and explosive diarrhea. No one tolerates this at treatment doses. However, we now use it as a booster because it's a potent CYP450 inhibitor. And when it inhibits CYP450, it lets us use the rest of the protease inhibitors as once-a-day meds instead of twice-a-day meds. So lower dose ritonavir just as a booster, not as an antiviral. The only protease inhibitor that is widely used anymore is darunavir. Everyone's going to tell you that darunavir has a sulfa moiety on the molecule, and to be careful with people who have sulfa allergies. And it's pretty much BS. Unless their sulfa allergy is anaphylaxis, I have no concerns about starting them on darunavir. because it's sulfur, not sulfa. Its sulfur side chain is different than what you find in Bactrim, what you find in Lasix. So it's unlikely that there'll be a cross reaction with that. Atazanavir is the other one that sometimes is still used. Atazanavir gives people Gilbert syndrome. So they get an asymptomatic, unconjugated hyperbilirubinemia that goes away as soon as you stop the medication. Needless to say, patients don't like it when you turn their eyes yellow, and they often stop this medicine if you tell them that's what's causing it. So people have gotten away from atazanavir because there are adherence issues because of its side effects. Atazanavir is one of those that needs stomach acid too. Can't be taken with H2 and PPIs. Blah, blah, blah. So no H2. So, you got darunavir here, and ritonavir as your booster. All in total, if you knew 10 HIV medications, you would get every single question on the boards right. So you're going to know about rilpivirine and H2 blockers, etravirine, and drug-drug interactions. You're going to know about Hep B activity, renal dysfunction, bone mineral density, hypersensitivity with abacavir. You're going to know about metformin and dolutegravir, and you're going to know about CYP450 inhibition by the protease inhibitors, which even darunavir does to a lesser degree. So drug interactions with the protease inhibitors are important as well. All right. So that is, what time is it? What time is it? Let's see. 25. Okay, I'm going to spend 5 minutes and then I'll be done. We're going to talk real quick about the combo pills because everything that you see is just a combo pill. All right, so we've got Genvoya, Triumec, Defc, Tarvi, Sintuza. Atripla is going over here. All right, Atripla was the first combo pill, one pill once a day. It had efavirenz, bad CNS stuff. It had emtricitabine, which is abbreviated FTC for unclear reasons to anyone. And it had tenofovir, old tenofovir in it. Bad drug, nobody uses it anymore. Some people are still on it because HIV patients don't like to change once they've gotten their virus under control. They're very reticent to change up their therapy. They say if it ain't broke, don't fix it. So I tell them that it is broken because they're having insomnia and they have brittle bones. So I take everyone I see on Atripla off of it, but I explain to them why. All right. Odefsey is a good version of Complera. I see people on this. If it's in parentheses, that means the same drug, but it just has old tenofovir. So Odefsey is rilpivirine, emtricitabine, and tenofovir. Complera just has TDF in it. Odefsey is a teeny tiny pill, but if they have any stomach issues, they can't take it. So when we're deciding which one pill once a day to put them on, we take all this stuff into consideration. Genvoya is elvitegravir plus cobicistat. So we have another pharmacological booster in this that's not HIV active. Emtricitabine and TAF. Genvoya used to be called Stribild when it had old tenofovir. All right. So that's really important because it's also a CYP450 inhibitor, so you have to watch for drug-drug interactions when you put them on this. Triumec is dolutegravir, so metformin, watch out. And Triumec is the only one pill once a day that does not have Truvada or Descovy in it. It has Epsicom, so you get lamivudine, which again is abbreviated 3TC, I have no idea why, and abacavir, which makes sense, ABC. Triumec is it's essentially that big. That's like the actual size of the pill, I think. Maybe not quite that big. It's really huge, and nobody likes to take it, but it was our best weapon when people had renal dysfunction, because all the other one pill once a days have tenofovir of some sort in them. So we used to use this drug a lot for people who had any hint of renal dysfunction, because Truvada, old tenofovir, Truvada is not supposed to be used if your creatinine clearance is on the downslope. All right.
No, like any amount of like function?
Less than 50. Creatinine clearance less than 50. Biktarvy is bictegravir, emtricitabine, and tenofovir, good tenofovir. So Biktarvy is essentially Genvoya minus the pharmacologic inhibitor. So a lot of people are moving towards this. This is why you see this one on TV advertised all the time. I don't know that any of you guys watch TV because you're all streaming millennials. But if you had television and you watched it, you would see ads for Biktarvy. And Simtuza is the only one pill once a day that has a protease inhibitor. It has darunavir plus cobicistat, and then of course it has emtricitabine and tenofovir. So these are really the big five you're going to see. So just knowing what's in them is important. It doesn't matter for the boards. They will tell you what's in these. They will never use the trade names. They'll give you the generic names for everything. But I think these are important to know when you're talking to the patients because they don't know their generic names. All right. 1 second on prevention. So there are currently two meds approved for the prevention of HIV through sex. Truvada and Descovy. So Truvada again is emtricitabine and old tenofovir. And Descovy is emtricitabine and new tenofovir. Both are approved for the prevention of HIV through sex. Truvada has been around for a long time. The first study, called the IPREX study, looked at 1,100 in each arm. One arm got Truvada, one arm got placebo. It was ethical then because we didn't know if it worked. In the placebo arm, 60 people got HIV. In the Truvada arm, 30 people got HIV. You say, well, that sucks. That's only a 50% risk reduction. They looked at those 30 people who got HIV. They looked at their blood samples that they had banked, and only one of them had detectable Truvada levels or detectable tenofovir levels. So we were giving them all these free medicine. They just weren't taking it. When you do the magic math that scientists do, it came out to like a 95% risk reduction with Truvada if you take it every day. You tell these people to watch out for kidney and bone stuff. It's really only approved for sex. The WHO recommends it in IV drug users, but the data is piss poor. The data would say that probably 50% risk reduction. And you just have to imagine that IV drug users, you're injecting it directly into your veins, whereas maybe it's a little less risky with sex. There's also a difference based on what your risk factor is. So the 95% protective value that I quoted is for men who have sex with men. It's slightly less effective in women. And the thought is that these drugs don't get the same concentration in the cervicovaginal tissue as they do in the rectal tissue. So Truvada is really good for MSMs. It's pretty good for women. And it's for IV drug users. Descovy had a head-to-head trial against Truvada and was found to be non-inferior. The Descovy arm had fewer HIV infections, but it wasn't statistically significant. It wasn't powered to brand it as superior. So it's non-inferior, but it was only tested in men who have sex with men and transgender women. So people who were biologically assigned female at birth cannot take Descovy for PrEP just because we don't have the data. And again, it has to do with, does this drug get into the tissues where it needs to be, the cervicovaginal tissues where it needs to be? We don't know the answer to that yet. These folks who are on this medicine have to get screened for HIV every 3 months to continue it so that we don't miss them getting infected and cause resistance by giving them an incomplete treatment regimen. They have to have their kidneys or their renal function in some way checked every 3 months, either with urinalysis or with a renal profile, depending on what their risk factors are for renal disease. And really the boon of PrEP is that you get these people who are having high-risk sexual behaviors into your office a lot, and you can screen the hell out of them for STIs. I probably treat more gonorrhea and chlamydia than anyone in Cincinnati because I do all the PrEP. Okay. Last thing I'm going to leave you with. So you notice all of these here are 3 drugs. So the paradigm is 3 drugs for the treatment of HIV. That's because back in the day, all we had was AZT. We said, okay, 1 drug doesn't work. Let's add the next NRTI that we get to it. We had 2 drugs. 2 drugs worked for a couple of months, and then they broke through. And then we got a second class. We got the NNRTIs. And we put 3 drugs together. It suppressed the viral load for 95% of people. However, is it because we had 3 drugs, or is it because we had 2 different classes? Probably the latter. And now that the protease inhibitors and the integrase inhibitors are around, there are a lot of studies looking at 2 drug regimens with an NRTI and 1 of these. There are currently 2 pills that only have 2 meds that are approved for the treatment of HIV. One of them has lamivudine and dolutegravir, and the other one has rilpivirine and dolutegravir. So we're getting there. It probably won't be 3 drugs forever. It's probably going to be more 2 drug regimens in the near future for naive people with no resistance mutations who are adherent and you trust. And see, done.
Can you talk about post-exposure prophylaxis?
Gene wants me to talk about post-exposure prophylaxis. So if you have exposure to HIV, you need to get post-exposure prophylaxis within 72 hours. You need to start it within 3 days. And it's a full treatment regimen. So you get Descovy or Truvada plus either dolutegravir or raltegravir. It all has to do with payer source and insurance. Truvada is cheaper, but Descovy has fewer side effects. Raltegravir is cheaper, but it's twice a day versus dolutegravir, which is once a day. And you treat them for 4 weeks. 4 weeks with a full treatment regimen. You check their HIV at baseline. You check it at the end of treatment, and then you check it again at 6 months. Make sure that they remain HIV negative. Oh, all right, yay, good job. Giving a lecture to no audience is really all right, bye guys.
Oh, they have some questions. Gordon asks, can you discuss HIV treatment during pregnancy and childbirth? I think.
So HIV, pregnancy and childbirth. Don't use dolutegravir. Don't use efavirenz. These are still, Truvada and Descovy are still kind of the backbone. Descovy is not well studied in women currently, so most people have you on Truvada if you're pregnant plus another agent. But you see all the newer agents actually have nuntenofovir. And our patients who are undetectable already going into pregnancy just stay on whatever they're on. But if you get a new diagnosis of HIV during pregnancy, you probably want to start the older version, TDF, just because it's better studied. Even though there's some concern about babies and bones. Let's see. Do I do any as-needed PrEP? So there's some data that if you know when you're going to be sexually active, when you know you're going to have high-risk behaviors, that you take 2 doses of Truvada that day and then 1 dose thereafter for a couple of weeks. And the data seems pretty good. There's no data for Descovy yet, so Truvada for on-demand PrEP. Oh, you're welcome, Gordon. Okay. All right.
I have a question. Yes, I know. Like CRISPR stuff. Is there any research on CRISPR and HIV or using it?
Yes. The answer to your question, Gene, is yes.
Can you describe all of it?
I cannot describe all of it. Thank you for this insightful question.
Oh, okay.
All right, bye, guys.